Hello, my dear students. I'm Dr. Vaishaly Bharambe. I've been teaching anatomy for the last 25 years and I love it. Today I've come with a very popular topic, the cubital fossa and its applied anatomy. My way of teaching it may be a little different for you because I believe that fossa doesn't mean you only have to understand that topic. You have to understand what are the structures in it coming from, what is the anatomy of each of those. It's understanding. Cubital fossa per se, I want you to understand its anatomy. I hope I get this across to you well. So where is the cubital fossa? It's a triangular space present in front of your elbow. Correct? How do we know about it? We know about it because we know that it is the place where the doctor puts his stethoscope when he's taking blood pressure. It's also the place where the medical professional puts in his needle when he is trying to aspirate blood. So we are aware of where is the cubital fossa. So we're going to study it as boundaries, floor, roof and contents, like we study any other fossa. Correct? Right, students. You know that cubital fossa is laterally formed by medial border of brachioradialis, medially formed by lateral border of pronator teres, and superiorly formed by an imaginary line joining the two epicondyles of humerus at the elbow. Let's understand each of these muscles now. First, brachioradialis, the lateral boundary. Brachioradialis takes origin from the humerus, upper two-third lateral supracondylar ridge, somewhere here. Descends downwards across to the base of styloid process of radius. Okay, this muscle receives its nerve supply from radial nerve, and what action does it perform? It's a flexor of the elbow joint. It is said to have to do its flexion best in mid-prone position. So if you want to make your brachioradialis prominent, put pressure on the forearm and try to flex your elbow. Automatically, the prominence you will see in your forearm laterally is your brachioradialis. It's also said that it is capable of bringing a supinated forearm to mid-prone position or a pronated forearm to mid-prone position. All these are actions of brachioradialis. Let's talk about the medial boundary, the pronator teres. Now pay attention. Here you can see the humeral head. It has two heads, a humeral head and an ulnar head. The humeral head will take origin from the humerus in the lower part along with the common flexor origin. And if you look carefully on a deeper side, you can see the ulnar head taking origin from the surface of ulna medial to the ulnar tuberosity. The two heads descend downwards and finally get attached onto the lateral convexity of the radius in the middle one-third portion. Okay, so on the radius, middle one-third on the lateral side is the insertion of pronator teres. Nerve supply, median nerve. Peculiarity. Oh, there is an important relationship. What is the important relationship? See, your median nerve, which is coming from your arm, descends downwards, passes through cubital fossa and exits by passing between the two heads of pronator teres. The superficial head is the humeral head. The deep head is the ulnar head of pronator teres. Right. So, we know the lateral border of cubital fossa formed by medial border of brachioradialis, medial border formed by lateral border of pronator teres, superior border formed by an imaginary line joining the two epicondyles. The point where the two muscles meet distally is called the apex, and the superior border is also called as the base. So we know these basics very clearly. Let's talk about the roof and the floor. It's a triangular structure. Okay, so we've got the boundaries. Now we have to know what covers it from above, what supports it from below, and then we go to contents. So roof. Any fossa has the same roof: skin, superficial fascia, deep fascia. Skin, superficial fascia, deep fascia. Superficial fascia again contains the same things: subcutaneous tissue, arteries, veins, nerves, lymphatics, and something additional. So in this case, superficial fascia contains fat. The arteries and lymphatics are quite nominal. We needn't mention them separately. However, venous network is very important. There are asterisks is put there because we will be discussing it here. The nerves present in the roof are also important and we'll be discussing those. In the deep fascia, the whole arm is enclosed by an antebrachial fascia of forearm, and it is further aided on the medial side by the bicipital aponeurosis, which again we will be discussing. So let's begin. Here you are seeing a lot of veins, the superficial veins of the arm. Okay, so you can see that laterally the superficial vein is called the cephalic vein. Medial vein is called the basilic vein. Both are, you can see there's a dorsal venous arch on my hand. The lateral end of it continues as cephalic vein. The medial end of it continues as basilic vein. Okay, the red triangle is representative of the cubital fossa. So which of these two veins is used for cardiac catheterization? Understand that this cephalic vein has to bend abruptly to drain into axillary vein. This abrupt bending might block the cardiac catheterization catheter, and therefore the basilic vein, which is comparatively straighter, is used for cardiac catheterization. If you look carefully, you can see that the two are joined here by a median cubital vein. Yes? And also draining into the median cubital is an anterior median vein. Let's learn more about this median cubital vein. The median cubital vein is a vein that connects the cephalic vein to the basilic vein. The blood flows from cephalic to basilic in that direction. What is the applied importance of median cubital vein? Why is this vein chosen over other veins? Are standard questions asked. Okay. So 1. What is the applied importance? It's the median cubital vein which is used for aspiration of blood, often for blood testing. Yeah, I'm sure you know that. Okay. And why this vein? Because this vein is often, it is connected below to the deep veins with the help of a perforator that passes through the bicipital aponeurosis. So this anatomy kind of fixes the median cubital vein in place. So if you put in a needle, if you were to put in a needle into any of these veins, my veins tend to move around a little bit. So the vein, it may be difficult to put the needle in, but median cubital vein is anchored in place by the perforator and therefore is quite easy to access. Also, the underlying bicipital aponeurosis prevents you, a new person who is aspirating blood, from entering into the brachial artery instead of the median cubital vein. So these are the reasons why you prefer to use the median cubital. Can you see here? This is the venous network and this is the needle aspirating blood from them. So these are the questions I asked you and these are the answers to it. If in case you have not understood, you can always read up from here. The same median cubital vein is also used for giving intravenous injections. It's also used for giving blood transfusions. It's a oft used vein in case of medical treatments. Right. Sometimes, however, you may come across some variations in it. For example, the median cubital vein may not receive anterior median vein, which may drain into basilic vein. Sometimes anterior median vein may divide into two veins. So there is no median cubital at all. One vein is the median cephalic vein and one vein is the median basilic vein. So these are some variations which are found. You should note it because you are the one who is fine. They're going to aspirate blood. They want to access the vein. So you should know its variations. Right. What about the nerves present here? There are two nerves present above cubital fossa, lateral cutaneous nerve of forearm and medial cutaneous nerve of forearm. So easy to remember, isn't it? But question is, what is lateral cutaneous nerve of forearm a continuation of? It's a continuation of musculocutaneous nerve. What is musculocutaneous nerve? It's a nerve that supplies coracobrachialis, biceps and brachialis. What about medial cutaneous nerve of forearm? Where is it coming from? This is coming directly from medial cord of brachial plexus. So now, having completed superficial fascia, let's go a step deeper and go to the deep fascia. The entire arm is covered by antebrachial fascia. It is further reinforced by the bicipital aponeurosis, which is seen here. Bicipital aponeurosis is a part of the tendon of biceps, which travels medially, covering all muscles of the flexor compartment of forearm in the region of elbow and gets attached to the ulna. Okay, so it gives that nice, beautiful, smooth contour to your medial aspect of your forearm as well. It's attached to the posterior border of ulna. It separates the median cubital vein from the underlying brachial artery, and it is pierced by the perforator which connects median cubital vein to the underlying deep vein. Right. So we've completed the roof. Let's talk about the floor. The floor is formed by only two muscles, medially brachioradialis, laterally supinator. We already know that brachioradialis takes origin from the humerus, descends downwards, posterior to the biceps, and gets attached to the tuberosity of ulna over here. It's a strong flexor of the elbow and receives nerve supply from two nerves. One is the musculocutaneous and other is the radial. What are such muscles called? Think about it and maybe you can answer in the comment section. The second muscle which forms the floor laterally is called as the supinator. The supinator is a little different because it's quite deep, taking origin from ulna, from annular ligament, radial collateral ligament. The muscle just winds around the upper part of the radius, somewhat like my hand, takes origin, winds around the radius and gets attached on the radius in this manner. Okay, so it gets attached to the upper 1/3 of the anterior surface of radius. The muscle is divided into superficial and deep parts. Receives its nerve supply from the radial nerve and its action is obviously as per its name. Supination. Which is the other strong supinator? The beautiful biceps muscle, isn't it? Right. Students, if you are enjoying this lecture, do like and subscribe to my channel. It will help me to make more of such videos. Of course, put in your thoughts in comment section. I would love to know what you're thinking about the lectures and make relevant changes accordingly. Right. So we are done with boundaries, floor, roof. Now we come to contents. Traditionally, the contents have been remembered by the mnemonic MBBS. M for median nerve, B for brachial artery, B for biceps tendon, and S for superficial branch of radial nerve. I would prefer to call it MBBR, but somehow I've seen students wanting to call it MBBS. Fine, whatever rocks your boat. Okay, so let's discuss each of these, okay? Here you're seeing the median nerve, which is descending downwards from the arm down, entering into the cubital fossa. As it's in the arm, it gives a branch to the pronator teres muscle and then it enters into the cubital fossa where it gives branches again to pronator teres, flexor carpi radialis, palmaris longus and flexor digitorum superficialis. Having supplied all this, it wants to leave the cubital fossa. Can you tell me how it will leave the cubital fossa? I have taught you this once. Passing through between the two heads of pronator teres. Absolutely. If you look carefully, here you can see the median nerve and you can see the pronator teres humeral head has been cut out to show you how the median nerve passes in the gap between the humeral and ulnar heads of pronator teres. Right. Let's now come to the next content, which is brachial artery, situated medial to median nerve, between the median nerve and the biceps tendon. So here is your brachial artery, which is now you can see dividing into ulnar artery and radial artery in the cubital fossa. You can see the radial artery giving rise to radial recurrent artery. Believe me, these arteries give rise to a number of branches, all of which cannot be seen easily. It takes meticulous dissection. What are these branches? Radial artery gave rise to radial recurrent. Ulnar artery gave rise to anterior and posterior ulnar recurrent. Recurrent are arteries that are going back up. Okay. Ulnar artery also gave rise to common introitious, which divided into anterior and posterior introitious arteries. You must be feeling, ma'am, this is getting too much. How do we remember all this? Fine, let's draw. Take a look at this image now. And here you can see the brachial artery descending in the cubital fossa, dividing into ulnar artery and radial artery. Radial is giving rise to radial recurrent, which is going up. Ulnar is giving rise to common introitious, which is dividing into anterior and posterior introitious arteries. The introitious artery is then giving rise to introitious recurrent, which is again coming up. Okay. Here the ulnar artery is giving rise to anterior and posterior ulnar recurrence, which anastomose with superior and inferior ulnar collaterals, branches of brachial artery. A lot of information, isn't it? Don't bother to remember it all now. Just remember one thing, that all these arteries are creating what is a elbow anastomosis. So every time you lie down on the bed and read in this manner, you are actually severely compressing the blood supply in the elbow region. And this anastomosis helps to preserve this region because when compressed here, the rest of the arteries remain open and the blood supply continues. Okay, so that is the point we are trying to make here. So what is the use of knowing about the brachial artery? You can use it for taking its position for taking brachial pulse. What are the positions or structures that matter when you take a brachial pulse? Can you do this with me, students, please? Straighten your elbow, slightly flex it till you can feel the tendon of bicep. Now go medial to it. Slightly straighten your arm. You'll be able to feel the beautiful pulsations of brachial artery. If you cannot feel, then you definitely need to join a gym. Okay? Because otherwise, everybody can feel brachial pulse. Alright? Can you feel it? Can't? Gym. Okay? Right. So, what are the relations that matter? The relation that matters, there is only one relation, that is the biceps tendon. Remember to go medial to the biceps tendon, semiflex and then slightly extend a little bit, you will feel the brachial artery pulsation. Right. Sometimes it matters that you know the anatomy even of the arm. If you have a supracondylar fracture of humerus as seen here, the sharp edge of it anteriorly can tear into the brachial artery, causing bleeding because of the damaged brachial artery. So that is why knowing about supracondylar fracture of humerus matters to us. The third content is the tendon of bicep. I am sure Salman Khan and all other famous bodybuilding bodies, male bodies, have already shown you what is biceps. I needn't tell you. But yes, bicep is a muscle that has two bellies, one coming from the supraglenoid tubercle, other coming from the coracoid process. Together they descend down, forming a tendon that gets inserted into the posterior part of the radial tuberosity. Anterior part, there is a bursa that separates the tendon from the rest of radial tuberosity. So that's the tendon of bicep, which lies lateral to the brachial artery. It's a very important relation. I'll keep on repeating this because this matters. What is the importance of knowing the relation between tendon of bicep brachii and brachial artery? One is, of course, we saw how to feel brachial pulsations. Another thing that it helps you is that you know where to put your stethoscope when you're taking patients' blood pressure. Suppose you don't know the biceps tendon, you would go anywhere and you would not be able to hear the sound in your stethoscope. So that is the importance of knowing the relation between tendon of bicep and brachial artery. So here you can see this person taking the blood pressure. Where is the stethoscope being placed? It is being placed over the artery in the cubital fossa. What is bicipital myotonic reflex? Biceps reflex, same thing. You are gently tapping the biceps tendon with the help of an examining hammer. If the C5, C6 is intact, the bicep contracts in the form of a jerk, which is what you are seeing here. This is helping you to understand the functional state of C5, C6, the way of taking biceps jerk. Finally, the last content of cubital fossa, the radial nerve. I want you to take the radial nerve from the arm, okay? The radial nerve enters into the arm here, giving rise to branches which will supply extensor carpi radialis longus, brachioradialis and brachialis. Now as it descends downwards, it enters cubital fossa, crossing the imaginary line between medial epicondyle and lateral epicondyle. Here it divides into superficial and deep branches. Deep branch passes between two heads of supinator. What are the two heads? Deep and superficial. Before it passes through, it gives rise to a branch to extensor carpi radialis brevis, ECRB. The superficial branch descends downwards under the cover of brachioradialis. It's a cutaneous branch. The branch that has passed through supinator and come out on the extensor compartment supplies the muscles of the extensor compartment. Okay? It's called as posterior interosseous nerve now. Right. So students, if you have enjoyed this lecture, please like and subscribe to my channel. It will encourage me to create more such informative lectures. So with this, students, I complete the topic of cubital fossa. Let's quickly run through what we've done today. We've understood the boundaries of cubital fossa. We studied each muscle, brachioradialis, pronator, teres. Then we talked about the roof. We should remember that the roof contains skin superficial fascia, deep fascia. But in superficial fascia, I want you to mention the median cubital vein, the venous network, and the two cutaneous nerves. Then we spoke a little bit about bicipital aponeurosis, and finally we went to the floor. The floor was made up of brachialis and supinator, only two muscles. And then after that, we came to the various contents. All the applied anatomy was discussed with the relevant topic. It's up to you to do that or enumerate the applied anatomy in the end of your at the end of your lecture. I hope this has been this lecture has been useful for all of you. I enjoyed taking this class. I hope you did too, attending the class. See you across the screen in some other lecture. Thank you. Bye.